Okay. Well, I'll introduce Kayla too. So Kayla Lashinger is one of our new genetics counselor. Um, she's been really wonderful to have her and has been helping many of our patients. So I'll let her talk about topics of genetics.
Okay. Thank you. Is everyone able to see my screen okay? Okay. All right. Well, thank you for the introduction and for attending this talk today. My name's Kayla, like Dr. McFarland said. I'm one of the new genetic counselors here at Fixel. And so today I'll be talking about different topics in genetics and Huntington's disease, including genetics background information and principles, talk a little bit about the modifiers, which you've all heard a little bit about, but I'll talk about those some more as well. And then talk about the utility of genetic counseling and testing and some specific examples that we might see come up in clinic. To start with a little bit about genetics background. So if we're thinking about our bodies, it's made up of trillions of cells. Within those cells is our DNA, which you can see wound up here. It's made up of those four letters A, C, T, G, and that creates a code based on a specific spelling. And specific sections of our DNA are called our genes. So these are like the backbone of our genetic code, and they provide instructions for our body, similar to a recipe for a cake, which Dr. McFarland talked a little bit about as well. They tell our body how to grow, function, develop, and we have 20,000 genes just about. And there is one specific one that is the main gene for Huntington's disease, which is HTT. It's on our fourth chromosome. And like every single one of our genes, we have two copies of this gene. So one copy comes from mom and the other copy comes from dad. And every gene has its own specific spelling that we consider the typical spelling. So for the HTT gene in a typical spelling, it might say for the recipe for a cake, it might say to add 1 cup of flour. But thinking about our genetic code and the letters it's made up of, that says add 1 CAG of flour. And then that provides instructions for making our cake. But if there are changes to the spelling of instructions, that changes how the body reads that and how it's interpreted. So if the HTT gene has a genetic change or a repeat expansion in the CAG that causes Huntington's, it causes different instructions. So instead of having 1 cup of flour, you have several cups of flour, but instead you have more CAGs than you typically should. So you have more flour, like any recipe, it's going to throw it off, and the cake is going to be different than it typically would be. But instead of a cake for our body, these are like the proteins. So the amino acids come together and form proteins, which are used for our body. And with Huntington's disease, this increase in your CAG number that we count in genetic testing is what someone is born with. But someone is not born with symptoms of Huntington's disease, and that's where the somatic expansion is something we're learning about and comes into play. So we know that this increased CAG number is an unstable region, and throughout someone's lifetime in all different cells of the body, that the genetic code is constantly replicated and it expands over time, particularly in the brain, until it reaches a certain point and causes neuron degeneration and then the symptoms of Huntington's disease. Um, and so that is why someone would be born with this but not have symptoms straight away. And that CAG number that many of you are familiar with and have seen on genetic test report has four different categories that we know and associations. So looking what a typical range would be, that would be in this 9 to 26 CAG repeat range. There is no risk for someone to have symptoms of Huntington's disease, nor any risk for their child to have Huntington's disease. Once we jump up past that and get into 27 above repeats, there becomes a risk for children. So the reason that there is a risk is because when you have 27 or more CAG repeats, it's unstable and it can expand when it's passed to a child. And once it jumps up to 36 or more, that's when someone has a risk for actual Huntington's disease symptoms. in this 36 to 39 range, that's what we call reduced penetrance. So essentially what that means, reduced penetrance, is that not everyone develops symptoms. Some people get symptoms in their lifetime, while some people never develop any symptoms. And we are learning a bit more about that and why some people have symptoms and some people don't, but we don't clearly know. And I'll talk a little bit about that when we talk about modifiers and what we're learning in differentiating who and who does not have symptoms in a lifetime. And then in the full penetrance range, that means that 100% of people who fall into this range will develop some type of Huntington's disease symptoms as long as they live a typical lifespan into their 70s, 80s. And then it can continue to jump up for children, but sometimes it can actually stay the same or contract in rare cases. But in these ranges, it can tell you if you will or will not develop symptoms, but it doesn't tell us what type of symptoms, their severity, or how their progression will look. But in general, we do know that a higher repeat number is associated with an earlier age of onset. So if someone has 60 or more repeats, that's when we typically start to think about juvenile Huntington's disease, which is before the age of 21. And the symptoms for that look a little bit different, but it shows that the higher repeat number means earlier age of onset. So you've probably seen something similar in a test report, whether I was the one who discussed that with you, another genetic counselor, or a different doctor. But essentially here, what you see are the two repeats that they report. So you can see on allele 1, there's 41 CAG repeats. Allele just means copy. So we have two copies of the Huntington's gene. One copy has 41 repeats, which is above that 40 threshold to cause Huntington's. And then the other allele or second copy has 20 repeats, which is in that typical range. So you can see that corresponds to the Huntington's change, and then that second copy is the typical change. And so that having just one change follows the autosomal dominant pattern that we see in Huntington's disease, and that's where that 50-50 chance comes from for any child of someone with Huntington's to have that genetic change. So someone could either inherit that copy with the change, or they can inherit that copy without the change. And so this is the main genetic concept that we know about in Huntington's and its inheritance, but we also know about another concept called anticipation, which you all have heard a little bit about. Essentially, what this means is that the repeat number increases throughout generations when it's passed from parents to children. This is more likely to increase if passed from a father to children rather than mother to children. But with the increased number is that earlier age of onset that we can see. And so specifically what the average is that we see in change of CAG repeat number if it's passed from father to child is about 4 repeats. Versus if it's passed from a mother to child, that stays about the same or increases just a little bit. And I mentioned sometimes it can actually go down that number, though that's not as common. And then you can see the corresponding change in the age of onset. So it's for father to child, the father had symptom onset on average of 41, then children have onset around 33, 34. Versus if it's maternally inherited, it's about a year and a half difference, so a lot closer in when people have symptom onset. But that being said, it is not always the case. Sometimes it can stay the same. Sometimes for each child, that change is different as well. So it's for an individual basis. And to look at that in a family tree type of example, if we start by looking here with the father, he's positive 41. Each of his kids individually have that 50-50 risk. It doesn't mean that 50% of all children will have the positive genetic change, but individually again. So theoretically, all children could test positive, all children could have tested negative. But in those who tested negative, that ends the risk going forward. So we wouldn't see a genetic change skip a generation, so there's no risk going forward for his children, grandchildren, etc. But then you can see the people who tested positive, each of their children were at a 50-50 risk, and you can see because it was paternally passed, there is more likely to be a CAG increase and jump in that. Versus here, if it's passed from a mother to child, it's more likely to stay about the same that we see here. And while it does in general tell you, okay, yes, symptom onset will be earlier, the higher your repeat number is, it's not always the case. And so even, for example, this mother and daughter here who both have 43 repeats, it doesn't mean that their symptoms will be exactly the same. They won't have onset at the exact same age. So to essentially sum that up, what another family member's HD looks like is not always a good prediction for what your HD will look like. And so I'd like to touch on the genetic modifiers. A lot of this is new and in research, so it's not something that we can look at in the medical setting yet, but it is hopeful that we're able to learn more about the variability in Huntington's disease. So CAG has been the core of our focus for many, many years in Huntington's. And in recent years, we're learning more about the rest of the genetic code, how it interacts with HTT, as well as other regions within that gene and how they influence the development and variability in Huntington's. So we no longer think, and we know that it's not just you have a CAG expansion that causes Huntington's disease. We know that there are several other factors within the Huntington's gene, like I mentioned, and throughout the rest of our genetic code. And so genetics is no longer the straightforward process which we think of it to be, and we're learning more about that web that intertangles everything and how the body interacts. So it looks a lot more like a network rather than point A to point B and what we see our genetics and conditions arise. And so we know that the CAG expansion is still the majority of Huntington's and causing that. It's about 60 to 70% of the variability, but then that other 30 to 40% is in the modifiers that I'd like to talk more about. So to start with those genetic modifiers within the HTT gene, we know that there is more to that gene than just the CAG repeats. And so people in general, the majority of people, 95%, right before their last TAG, they have this CAA interruption. We also know that right after the CAG sequence comes repeating sequence of CCG. And majority of people, again, they have this CCA interruption. And essentially what these interruptions do is they help to stabilize this long stretch of repeats and make it easier to replicate without being prone to changes or defects and differences in expansion. And so we're learning, as I mentioned, that some people do not have these interruptions. So some people don't have a CAA interruption or a CCCA or CCA interruption, or they don't have either one of them. And we have found that this might cause people to have symptoms at an earlier age, possibly up to 10 to 15 years earlier if they're missing one or both of these interruptions. And then we also know that some people actually have an extra one of these CAA interruptions. And we think it might help to have symptoms start at a later age, but this has not been entirely certain. It has been a bit contradictory in different studies, partially because it is already so rare, with only 5% of people having an extra or difference in the interruptions, and that makes it difficult for us to study. Also, going back to that reduced penetrance range and how some people develop symptoms and some people don't, this may explain some of that. And so some studies have found that people who are in the reduced penetrance range and lack this interruption are the ones who go on to develop symptoms, but there's likely more that's contributing to it than just the lack of this interruption. So this area that we're looking at is actually less than 1% of the entire HD gene. It's part of a specific region called exon 1, which you hear a lot about. It's a lot of target and research and clinical trials, and it is the main area where we had this CAG. But there's a lot more to the Huntington's gene than just this region. So you have exon 1 where the CAG repeat is, you have the intron, and then that goes all the way through exon and intron 67. Essentially, exons are coding areas and introns are non-coding areas. If you kind of think of it back to genes being like instructions for a recipe, you can think of the exons as the main ingredients and instructions, while the introns are kind of like extra note section, almost like footnotes in a book. So they're not directly relevant to making the cake, but they are helping you and giving you extra tips and directions. And you can also see that there's two little areas at the start and end of the gene, and these are kind of like control centers. This one right here tells the process to start and guides it when reading through and tells it to read through the spelling of the gene. And so with making our mRNA and making amino acids, first the introns are cut out and you're left with that. And then you have the amino acids that come together to form the protein. And this is how the typical genetic process works for our genes. And so that protein is that cake we keep talking about that we're trying to make, which the body uses. But in Huntington's, it's proposed that that CAG number in exon 1 causes there to be something wrong with that control area at the very start of the gene. And it causes the protein to be shorter than it should and causes harmful effects on the body. And so this is something that, as I mentioned, research is looking a lot into to see if it can be targeted. And then outside of the Huntington's gene, outside of HTT, we have nearly 20,000 other genes in our body. And there is a growing list of those that we think are involved in Huntington's and affecting it. A few of them are listed here. Majority of them so far are what we call DNA repair genes. So they go in and they fix the DNA. For example, as the DNA in the CAG repeat is expanding and we have more CAGs, it's more prone to changing, and these DNA repair genes have a impact on that. So if they're not working properly, then the DNA is not able to be fixed and it can cause the expansion to keep growing and cause symptoms of Huntington's. But there's a lot of new exciting findings that we're finding out about Huntington's and the ways that the rest of our genome interacts with the HTT gene. Hopefully soon there will be something more applicable to the medical setting for you all and for other patients as well, based on this research. And then I'll briefly talk about genetic counseling, what it is, and then different reasons someone might see a genetic counselor. But after we finish this presentation, I'll have my email up if anyone has any questions. I'm happy to answer those as well. So lots of this information I've discussed is not super personal to you and your families, and that's where I come in and other genetic counselors come in to provide individualized counseling with medical genetics information, talk about your specific family history and specific symptoms and any impacts, emotions related to genetic testing and learning about results as well, and then connecting with resources as well. That's another part of our role as a genetic counselor. And this might be in the setting of predictive testing. It's someone who doesn't have symptoms of Huntington's, but they have a family history. It can also be what we call confirmatory testing for someone who has symptoms of Huntington's and they're pursuing genetic testing. But it can also be completely unrelated to genetic testing. It can be answering questions, education, risk assessment, management, all of that is something that we can discuss with you and direct you to the right resources as well. And then prenatal genetic counseling in the Huntington setting is also a possibility, though it's not something that we do here at Fixel, but it's something that we could definitely connect you with if you or a family member is ever interested. So as I mentioned, predictive testing is for those without concerns of Huntington's, but they do have a family history. And like any type of testing for Huntington's, there's a lot of considerations that someone might have. People might want to pursue testing for life planning, for their career, finances, having children, getting married, but also just for personal need, wanting to know, relieving some uncertainty, and having an answer. But considering what risk could arise with this, some people want to put insurance in place before moving forward with genetic testing because there are laws that protect against this, both within the US, called the law called GINA, or the Genetic Information Non-Discrimination Act, that protects for employment so long as the employer is more than 15 employees and it's not through the US government or military. And that also protects for health insurers. So someone cannot be denied employment, they cannot be fired, they cannot have their premiums raised, denied coverage based on a genetic test report as long as they are asymptomatic. But people still like to put this in place just in case, because we don't know how well tested this law is. And then in Florida, there's additional protection for long-term care and life insurance. Other people want to thoroughly think about how would this impact my relationships with other people, with myself, in my community, and then recognizing that testing will give you a partial answer, but not a full prediction of the future. It can't say again what will specific symptoms be, their severity, when will symptoms start. And at this current point in time, it does not change anything about disease progression or preventing the disease. So these are all things that people might consider, but again, it varies from person to person. And for someone pursuing predictive testing, there is a protocol that we follow that is designed by the HDSA and the Genetic Counseling Society. So it usually starts with the phone call before your first visit, just discussing any questions you have, talking about the general process, and then talking further about insurance implications if someone wants to put that in place. Then the first visit, you'll come in, preferably in person, and we strongly encourage a support person, particularly someone who is not directly at risk for Huntington. So that might be an unaffected parent or a spouse. And at this visit, you meet with myself, Dr. McFarland, and Alana for social work. And then if you choose to proceed with testing, we can provide you with a consent form that you bring to a lab to have your blood drawn. And then you come back about 1 to 2 months later for that second visit. Again, we encourage you to bring that support person. And at this visit, we go over results with you and navigate the day as is appropriate for you and what fits your needs. And then I usually have a follow-up call about a few weeks later just to check in, answer questions, and see if there's anything else we can do for you before that next visit or next follow-up. Because at that second visit, getting results is usually enough information to take in for the day. So don't want to bombard you with information when you're getting results as well. And so that's why we have that follow-up call. And so we talked about predictive testing for people who are asymptomatic but have a family history. Confirmatory testing is a little bit different since it's for people who have Huntington's disease symptoms. Some people may have a clear family history and some people might not have any family history, but it's still possible to have Huntington's without clear family history. So similarly, there's different benefits and risks that people might weigh when they're deciding to do testing. It can help in confirming your diagnosis and informing recurrence risk to family members, getting assistance and qualifying for disability, but it is still an option to you if you would like to proceed with testing or not. And then there can still be some of that uncertainty, but having this confirmed diagnosis is helpful for a lot of people, but not the right choice for everybody. And then just to quickly touch on prenatal pre-implantation genetic testing, which is organized by prenatal and preconception genetic counselors and different PGT IVF clinics. This is for couples who are at risk for Huntington's disease transmission. So that parent of the possible baby might have a family history or they have confirmed Huntington's disease themselves. And so that can be tested for before pregnancy. And there's actually a grant through Help Cure HD for PGT IVF and families with a history of HD that can help them support them through this process since it is pretty expensive and also is emotionally taxing type process as well. And in some cases, this can actually be done anonymously for the at-risk parent, so they don't have to know their own status, but that varies from clinic to clinic. Usually it does require DNA to be banked from someone who had confirmed Huntington's disease, so that would be likely the grandparent of the future child. And then during pregnancy, there's testing with CVS in the first trimester and then amniocentesis in the second trimester. But these are typically only offered if they would affect someone's decision to either continue the pregnancy or to terminate it based on the results of Huntington's. Because otherwise, it can cause some ethical dilemmas and taking away the child's future autonomy since this is an adult onset condition and it wouldn't change anything about preventing the disease to test in childhood. And so just want to also touch on some common questions that come up. This highlights a few points I talked about, but a lot of people will have different repeat numbers from parents to children. So if a mom's genetic testing shows 44 repeats, a patient shows 43, and the sister shows 46, what can cause some of that variability? As I talked about, that can actually decrease in size if passed from mother to children, and that risk is independent for each child. So that would explain that. But also with the way that genetic testing works, it reports the repeat size within a range of usually plus or minus one. And that's because the genetic testing doesn't actually count the number of CAG repeats, but it rather measures the length that includes that CAG repeat. So it doesn't say is there or is there not a CAA interruption. And so that could be a possible, though not as common explanation for this. But hopefully that will change in the future of genetic testing and we'll have more accuracy and precisely say how many CAGs are there, is there an interruption, etc. And then touching on testing children for Huntington's, it's not something that we ever do or recommend unless there is a concern for juvenile Huntington seen by a neurologist. Otherwise, we wait until someone is 18 years old to make that choice for themselves because, as I mentioned, it has no medical implications and we want them to choose for themselves. And then we want to limit any type of possible discrimination in various instances for etc. or for example, adoption, employment, school insurance, any of those. We don't want to do that without the child having their choice in the matter. So I will leave you all with a few websites to find additional information. One of them is the National Society of Genetic Counselors website. If family members are not local to Florida and want to find a genetic counselor near them, this is a great resource as well as just learning more about genetic counseling. And then we have lots of great tools and resources on our website, fixel.ufhealth.org. And then HDSA, HDYO, and honestly HD are just a few of the many wonderful patient advocacy organization that have lots of educational information, support groups, different events that you can look into and choose to be involved in if that fits your needs. But that's all I have for this afternoon. I wanted to thank you all so much for listening. I have my email and phone number here if there's anything that you all need. Additionally, I'm always in clinic if you'd like to set up an appointment with me or while you're here for your visits with Dr. McFarland and our team. Thank you.